Well, good evening, everyone. It's 7 o'clock. If I could just get a sound check, someone could just throw it in the chat. Sound is good. Thanks, John. Your chief sound tester. That's good. Assuming everyone can hear it. Lovely. Thank you very much. Very warm welcome along to this next episode. So we're on number 4 now, aren't we? Just had a quick look through the guest list. There's quite a few familiar faces there, so good to see you all. Thanks for coming back, and a few new faces, so welcome along. We hope you find this useful. Yeah, Sadie, that's fine, no problem at all. So good evening, those of you that are new to this. Welcome. We're STC Training Solutions. We are a first aid and pre-hospital training provider based in Aylesbury. And we have been doing these online webinars since, well, with a bit of a gap since around this time last year. Started with an ECG series, and then we've been doing some material set up specifically for those of you going through the FREC pathway, which is what this series is all about. The interactive CPD series is subjects that we've picked which we think would be useful for those of you going between FREC 3, FREC 4, and of course beyond FREC 5 and into paramedic science, those of you that are doing that. It's part of it. It's going to be quite a long series, actually. We've identified quite a few areas that we want to talk about. And we hope if people are finding that useful. So my name's Innes. I'm a paramedic practitioner by trade. I work in a GP surgery and also a couple of bank contracts with local ambulance services, NHS trusts, and so just keep my hand in with emergency work. And I've been doing that for 8 years now, 8 or 9 years now, so it's gone very quickly. So as I say, a lot of familiar faces in there. Those of you that are just joining, you've not missed anything, so welcome along. Just give you a minute or so just to get settled in. As I say, predominantly we are a pre-hospital care training provider. We specialise in providing the FREC pathway. So we do have some courses coming up if anybody that's listening is interested. We're running from Aylesbury at the moment. We have a couple of FREC 3 courses coming up over the next few weeks. They are filling up fairly quickly, actually. So if you want a space on one of those FREC 3 courses, please do get in touch. Just missed a FREC 4 course that started this past weekend, so our next one starts in 8 weeks time, so on the 10th of July. Still space on that one. Safe administration of life-saving meds, which is the really useful bolt-on to FREC 4, which allows you to deliver some of the medications we're going to talk about tonight, actually. We've got a course starting on the 17th of July. And ILS, of course, anyone that has their FREC 4 or FREC 5 needs to do an annual ILS qualification. Our next one of those is coming up shortly, and that's on the 27th of June. Okay, anyone that's found us through our webinars is entitled to 10% off, so please do use the discount code webinar10 at the checkout when you buy online. But we hope to see some of you face to face on some of your courses at some stage. So fab. So welcome along, everyone. Good evening, all of you. So we've got some people from all over the place, which is great. We normally do have quite a wide spread, so all the way from Orkney and Wales, and no doubt further afield as well. So welcome along to all of you. We'll get going then. In that case, it's just gone 7 o'clock. Those of you that have been watching the series already will know that we've already covered the CPD requirements of holding a FREC 4 certificate in particular, and FREC 5. And we've also talked through some anatomy and physiology. So we're now going to start talking through some of the pathophysiology, which means the study of disease. We're going to go through the systems kind of one by one. So tonight we're going to focus around the respiratory system. So some of the things that can go wrong with the respiratory system, and hopefully you'll find that useful in your studies wherever you are in this kind of case. Once we've finished pathophysiology, we're going to look at some maternity care. Those of you that watched the first series of CPD videos back at the end of last year will see some new material coming out. So patient assessment and paediatric assessment, we're going to talk about again sepsis, including any latest guidelines, oxygen and Entonox guidelines, and we'll do some stuff around ECG Basics, and of course intermediate life support. Doesn't replace your need to do an annual face-to-face course, but hopefully just keeps you up to date with any of the latest changes, as many will be aware that European Society of Cardiology and Resource Council UK have recently updated some of their guidance. So we'll cover some of the changes that are applicable to us. So tonight well, for the next few weeks, we're going to be looking around pathophysiology. Tonight we're going to be sticking particularly around the respiratory system. So we're going to look at what asthma is, COPD, and then we're just going to talk a little bit around respiratory tract infections. There are many of them, but just to give you some idea of how they work. And then of course there's the usual Q&A session at the end. That being said, if you have a question at any point, just throw it in the chat and I'll do my best to answer it as we go along. There will be some natural pauses where I can look back at the comments that are coming in. So do throw those in there. We like these sessions to be as interactive as possible. So if you've got your smartphones, just have those ready. And get it to menti.com. It should ask you for a code when we get to the interactive sessions or the interactive parts of tonight's session. It'll ask you for a code. We'll give that to you and you can answer the questions. Your answers appear live on the screen in front of us so we can all see that, which is good. As you go along, you can always pop comments in the chat. As I say, you can tweet us, email us or text us even after the event if you have any burning questions that didn't get answered. So hopefully you're sitting comfortably. Welcome along to those of you that have joined. You haven't missed any of the material yet, just the hellos. So come in, get comfortable, and we'll get going. So there is some recommended reading set by Qualsafe and also from what we found useful over the time that we've been a FREC centre. So if those of you that have done your FREC 3 should have been provided with a copy of Ambulance Care Essentials, that does cover most of the subjects that we're talking about tonight. Those of you that have done FREC 4 or doing FREC 4 should have been provided with a copy of Ambulance Care Practice. You should also have a loan at least of Ross and Wilson Anatomy and Physiology from your FREC centres. If you're not currently enrolled in a course, then these are available to purchase through our website. And a book that I find quite helpful is the Pathophysiology, a Practical Approach from Rachel Story. It's really only aimed at those of you that want to go higher than FREC 4, particularly anyone that's interested in going on and studying paramedic science at any point. Then there's some really interesting stuff in that book. All of these books are available to purchase from our website, and the Ambulance Care Essentials, Pathophysiology and Ambulance Care Practice are all available with free delivery. So let's get interactive then. So the first interactive part tonight is just to bring your minds back to what the functions of the respiratory system are. So if you go to menti.com, put in the code 17025604, the code shown at the top of your screen, 17025604. And you should be able to answer the question then of what are the functions of the respiratory system. You get to put up to 3 answers, 3 short answers. So pop them up there and they should appear on the screen. So pop it into menti.com, Sadie, if you can, it'll pop up on the screen. Go to menti.com, 17025604 is your code. It's in the chat. Charlotte's just put that in, and then just answer the question. There we go, lovely. Gas exchange oxygenation, fab. O2 in, CO2 out, good. A few people saying gas exchange, that's brilliant. Let's give a few of you the chance to, there we go, look at this. Fab. Some good answers coming in there. Most of you saying gas exchange, which is brilliant. That is the fundamental function of the respiratory system, of course. Gas exchange, replacement of toxic gas, oxygen, oxygenation, exchanges, breathing, CO2 in, CO2 out, yeah, good. Gas exports, oxygen in, O2 in, CO2 out. pH, yeah, good, that's a good one. So the acidity level of the blood. Excellent. Exchanges, good. So most people coming in there with gas exchange, which is absolutely correct. So fantastic. Let's flick back then. So just to remind ourselves what we're looking at here then. So pulmonary meaning the lungs, the physiology, how they work. So how do the lungs work? So we have these structural units that you can see on the left here called alveoli. Alveoli are little sacs. And I think best to think of it actually as a student of ours that came up with this, but best to think of them as little rolls of bubble wrap. That will become apparent as to why I think of it a little bit later. But think of them as little bubble wrap. They've got some rigidity to them, but they do kind of expand and contract with every breath in. The whole purpose of the respiratory system is to get air in and out of these little sacs at the end of the very kind of terminal bronchioles, the tiny little airways that kind of split and split and split from the main airways. So getting air in and out of there allows gas exchange to happen. So this little diagram on the right just goes to show very briefly what's going on there. So we have we have blood coming through the pulmonary artery. That's of course coming from the right hand side of the heart and is deoxygenated, okay, low in oxygen, high in carbon dioxide. The blood going back to the heart is obviously high in oxygen, low in carbon dioxide. That makes sense, because that's obviously then going to go to the left side of the heart and be pumped around the rest of the body where that's going to be used. So what we see here, the gas exchange in the alveoli, is that carbon dioxide is going to leak out of these blood vessels, and oxygen is going to leak in. Now it does that through a concentration gradient, does it through a process called diffusion. These cells around the capillaries that surround these alveolar walls are all one cell thick, and they're permeable to gases such as oxygen and carbon dioxide. So if you have an area of high concentration, that gas will naturally move to an area of low concentration. The area of high concentration, as the blood comes around here, is within that pulmonary artery, within the pulmonary arteriole, should we say, as it comes into the capillary bed here. There's a high concentration of carbon dioxide, and that will naturally diffuse across into the alveoli, because assuming we've just taken a breath of room air, that we're not going to have much carbon dioxide in the alveolar sac. So of course that diffusion goes across that way, and then you can see at the same time, simultaneously, we're creating an area of high concentration of oxygen within the alveolar sac, and we've got a relatively low area of concentration of oxygen in the blood, because it's all been used up by the body. So of course it diffuses back across the two cell walls in the reverse direction. So that's going on in every single capillary bed, in every single alveolar sac within the lungs, and there are thousands and thousands upon thousands of these in each lung. So you can see that they're a very efficient system. But of course, if you block too many of them up, we end up with problems. And the whole purpose of tonight is to try and understand some of the processes that stop air getting, or at least make it inefficient, stop air getting in and out of these alveolar sacs correctly. And of course, if we do that, we're going to see a definite pattern of deranged observations. If you stop gas exchange, you're going to see carbon dioxide being retained, so carbon dioxide will stay high, and of course oxygen won't transfer in, so the oxygen level, so the blood that comes to the alveoli may not change that much if there's no fresh air coming in and out of here. So of course you'd expect to see oxygen saturations decreasing, you'd expect to see end-tidal carbon dioxide increasing. In response to that, the body's going to breathe faster, it's going to beat the heart faster. And of course you're going to see that distinctive pattern then, aren't you, of decreasing saturations, increasing carbon dioxide, increasing respiratory rate, increasing heart rate, and you can be certain that there's probably something going wrong with the gas exchange. And then your next job is to try and figure out what's one of the many causes of impaired gas exchange. So we're going to go interactive again. So back to the same menti.com, it's the same code. We're going to go to the next question along, which is going to ask you, what is asthma? Okay, so again, you can put up to 3 answers again if you wish. So what is asthma? You can even think about how would you recognize asthma, but put some answers in the box. So go to menti.com 17025604 and pop up to 3 answers. There we go. Charlotte's just pop that in the chat again. Menti.com 17025604 is the code you need to put in. Lovely. And what is asthma? And you can of course talk about how would you recognize asthma as well if you wish. Good. It's obviously a word limit, isn't there? Conditions affecting me. Good. Constriction of the airways, spasm, hypersensitivity, allergic reaction. Good. Inflammatory disease. Yep. Good. Breathing disease, breathlessness, wheezing, bronchospasm. I like it. Restriction, tightening of the trachea. I'll say that the trachea often doesn't get affected too much. It tends to be a smaller airway disease, but say the bronchioles generally. Good. Restriction of airways, good. Inflammation of the lungs. So it's the airways within the lungs, lovely. Obstruction due to a trigger, yeah, good, I like that. Spasm and shortness of breath, inflammation, I like that. Let's go back and see what asthma is, because it's three very distinct processes actually. So of what is causing asthma. So asthma is an allergic response to a trigger. Now that trigger affects a patient with asthma, but it doesn't affect a normal healthy person. So common things are things like pollen, smoke, animal hair, things like, so particularly in London, we see diesel fumes, so pollution in general, Of course, some work that we do may produce dust and other such things and other pollutants that we react to. But asthma is an allergic response. It's not a normal response. So you'll find that the vast majority of the general population won't have asthma when exposed to pollen, but somebody with asthma will. And there's three distinct processes that go on. Okay, so you have number one is bronchial constriction. Bronchioles are the small airways. Okay, so the main bronchi, the left and the right main bronchus, when it splits and splits and splits, it splits into smaller airways, which are called bronchioles. Now they have muscles around them. It's quite useful for the body to be able to control air going in and out of those. So they have little smooth muscles around those tubes that can contract and relax. And when they contract, the airways become smaller. What happens in asthma, one of the main problems that's going on is that those muscles constrict, and those muscles constrict, they make the airways smaller. That's okay on its own. Obviously, when it's diffuse, when it's happening all over the lungs, that will start to make you tight-chested and wheezy. But of course, we get two other processes going on. So we get bronchial edema. Edema just means fluid buildup. So you start to get swelling of the lining of these small airways. So not only is the muscle outside contracting, you're also starting to get swelling of the soft tissue within it. Again, both of these things are making the lumen, the air space that the air can pass through, ultimately trying to get to the alveoli. It makes it smaller. And then, of course, the third process is we start to produce excess mucus in response to that allergen, that thing that our body is allergic to. So all this excess mucus, again, further plugs these tiny little airways. Okay, one of the reasons why asthmatics cough so much when they're given salbutamol. Salbutamol is the first line drug to relax this muscle spasm and allow these tubes to open again. Of course, the first thing we try and do is cough up all this excess mucus. These three things together make it very, very difficult to get air in and out, and specifically out of these alveolar sacs. Okay, so if we're impairing this air moving in and out, we're going to at some stage impair gas exchange, aren't we? If we can't get air in and out of this alveolar sac here, for example, we're going to build up carbon dioxide, which means we're going to lose the concentration gradient, and we're going to lose, we're not going to replace any of the oxygen level that's being taken by the blood returning to the heart. So again, we're going to lose our concentration gradient. When that happens, the blood that comes to this alveolar sac leaves in exactly the same chemical buildup as when it came, which is no use, obviously. If this happens across large proportions of the lungs, we're going to start to see systemic responses, aren't we? We're going to see low oxygen, we're going to see high carbon dioxide. In response, we're going to see breathlessness, we're going to see high heart rate, and a patient that's deteriorating. Ultimately, that keeps going. So that's what's going on in asthma. How do we recognise it? So we've talked a little bit about it. So one of the things we talk about is how able is the patient to speak in full sentences. If a patient isn't able to complete full sentences, we tend to think of that as a bit of a red flag of asthma. Airway, it's the characteristic wheeze, isn't it? You might be able to hear it without your stethoscope, but you certainly should be able to hear it with popping your stethoscope on the patient's chest. You should hear that characteristic expiratory wheeze generally, although you can get inspiratory wheezes as well. The wheeze is caused by air being squeezed past a small space. So very much the same way as when you whistle. It's exactly the same thing going on in your small airways. So with the breathing side of the primary survey, clearly we're going to have visible dyspnea. Dyspnea means difficulty in breathing. Visible dyspnea means you're going to see accessory muscle use. You're going to see straining of these tendons within the neck from the neck and shoulder muscles. We're going to see an increase in respiratory rate because the body's going to sense that the carbon dioxide is increasing because the lungs aren't working efficiently, and its quick response to that is to speed up breathing and to try and clear that carbon dioxide. So we're going to see an increase in respiratory rates, and as we've mentioned, because we're losing that gas exchange, we're losing that concentration gradient within the alveoli, we're going to lose our our saturations are going to drop, and our end tidal carbon dioxide is going to rise if we're able to measure it. So circulation wise, the heart and the lungs are intrinsically linked, but ultimately if the body detects that it's becoming deoxygenated, hypoxic, one of the other responses is that we start to pump the blood around faster because the body seems to think that maybe the blood is not carrying itself efficiently, and actually it just needs to be spun around the body faster. So one of the responses you'll get is an increase in heart rate. Blood pressure doesn't really change that much. It's more likely to go up through the initial stress. Blood pressure dropping in somebody with asthma is likely because they are becoming peri-arrest, i.e. about to they had to go into cardiac arrest. Cyanosis, that bluing of the peripheries, is likely going to be a late stage, and that's as a result of the low oxygen levels, as we know. I put ECG in there because we tend to, as FREC 4, certainly we're keen to do ECGs, and you wouldn't expect to see any acute ECG changes in somebody that's having an asthma attack, other than heart rate changes, obviously sinus tachycardia perhaps in those early stages. In terms of disability, D section of your primary survey, GCS, so your level of consciousness may well start to reduce in those later stages because of the hypoxia again. Not likely to see any changes in blood glucose with somebody that's having asthma. And pupils, you're not likely to see any difference with the pupils. Pupils equal round, reactive to light, and accommodation. That's just the kind of medical jargon for the pupils are equal and reactive. So that's how you would jot that down in shorthand. But you're not likely to see anything different with pupil response shining lights in that, until of course they become completely unresponsive and peri-arrest. You might start to see the hypoxia dilating the blood, the pupils. In terms of exposure examination environment, we're not expecting a temperature with asthma, are we? That's key. How can we tell the difference between asthma and a raging chest infection? Is often the temperature and the history, of course, getting some history. So because it's an autoimmune, sorry, not an autoimmune, it's because it's an allergic reaction rather than an infection. Infection is when we see our body turn up the temperature. We don't tend to see that in asthma, so you would expect a normal temperature. Good. We can classify asthma. This is taken from JR Calc, so if you have access to JR Calc, then have a little read through this. They do explain it quite well. But there's generally speaking 3 or 4 stages of asthma, depending on what you're taught. So we have this kind of mild to moderate stage where these are adult figures. They do have child figures in JR Calc as well. We're only just going to focus on adults tonight because of time. But if their respiratory rate is less than 25, their SATs are still over 94, their heart rate's still below 110. I'll come back to this kind of what we mean by peak flow, and they're able to speak in normal sentences, then we would class that as probably mild to moderate, and you would use your clinical judgment as to which one you would call it. Peak flow, peak expiratory flow rate. It's those tubes. You get the patient to form a seal around it and blow out as hard and fast as we possibly can. So that is that's to try and establish how quickly they can empty their lungs, and it's measured in liters per minute. So and the idea is to blow the gauge as far down as they possibly can. JR Calc has a useful table, or like a graph, that you can use to roughly estimate male and female approximate heights, how much their peak flow should be if their lungs were perfectly healthy. And what we're doing is we're looking at the percentage of that predicted value. So for example, me, I think last time I looked, I was supposed to be about 520 or something like that. So I should be able to, my peak expiratory flow rate should be in the region of 500 to 550, something along that range. Obviously it's slightly less. It drops with height, so that shorter people don't have as much ability to empty their lungs quickly, and women statistically have lower peak flows than men for the same height. So we would use that graph in JR Calc. You're not expected to memorize that by any sense, and then you would calculate the peak flow that they actually produce on the day. Is it within 50 to 75% of their predicted reading? If it was over 75%, we're probably going to say that this is a very mild asthma attack. We're looking for that drop of at least 25% before we're calling it asthma, to be fair. So if we're in that 50 to 75% region, we're safe to call this fairly mild to moderate. Peak flow is very, very useful for grading asthma, and that's why we do bang on about doing it. So moving into severe, then we're expecting to see this respiratory rate. So any one of these really is going to start to bring you into severe. So the respiratory rate's over 25. If their SATs are kind of hovering 94 in that 92 to 94 section, heart rates peaks over 100, that the percentage of their predicted peak expiratory flow rate is between 33 and 50%, so between a third and a half. And or we're unable to speak in full sentences. We're now starting to call this severe. Okay. Once our saturations start to drop, the only real difference here is saturations start to drop and their peak flow becomes less than 33% of the predicted value, then we would start to call this life-threatening, and we do need to act. We need to be not, there is that tendency to be complacent with asthma because so many people have it. But absolutely, we do need to see some There's some fairly quick action from that point. I've put some other useful things that might guide you towards this being life-threatening. Reduction in level of consciousness, clearly, because the patient is not getting enough oxygen for the brain to function. Exhaustion, particularly in children, exhaustion is a bit of a key. If you're working ridiculously hard with those respiratory muscles and you run out of stamina, clearly the next thing that's going to happen is your muscles are going to stop for a break. And you're not going to have the spare oxygen to cope with that. So dropping blood pressure, again, suggests that patients are heading towards that cardiac arrest stage. Cyanosis, again, not a nice thing to see in someone that's suffering with asthma. Silent chest, what we say with silent chest is when you listen to someone going through the phases of an asthma attack, you hear the wheeze very, very loud. When that wheeze starts to quieten down, and it's not as a result of them getting better, it's because actually there's just no air moving in their lungs. So once the lungs become quiet, that means that there's no air moving in and out. Ultimately, the next stop is respiratory arrest and death, isn't it? So respiratory failure, i.e. loss of respiratory effort to the point where you're starting to bag them, we're moving then into near fatal. And abnormal end-tidal carbon dioxide I've put in there, specifically if end-tidal carbon dioxide really shoots up, then we're really moving into this near fatal grading. Near fatal is just kind of an awareness of actually we've gone from life-threatening to we need to do something to help this patient. So respiratory failure requiring positive pressure ventilation, so that's bag valve mask normally, with or without the rise in end-tidal carbon dioxide. If you're bagging someone, quite clearly they are very near to death, aren't they? So with the bag valve mask. Petechial hemorrhage around the neck, John. So it's more likely you're going to get petechial hemorrhage around the face and around the eyes with extreme difficulty in breathing. You tend to see that more with people that have been asphyxiated or choked or so on. But you can indeed see it in patients that are really struggling for breath. So yeah, good one to pick up on. So where are we? There we go. So treatment for asthma. So I'm going to put just a very generic treatment up here for asthma. The things in black anyone can do. The things in blue, you do need to have your safe administration of life-saving meds bolt on or some other kind of qualification. So the book says, number one, calm and reassure, and ideally, if possible, move your patient to a quiet environment. That's because any additional stress is only going to make that feeling of breathlessness and feeling of panic worse. So calming and reassuring, moving to a quiet environment, you'll be surprised how much that actually does help, particularly in that mild to moderate phase. Okay. Ideally, now this is again, depending on where you work, certainly if you go and work for an NHS trust on frontline ambulance, you'll be expected to measure peak flow before and after treatment. Sometimes it can be quite difficult to get the patient to agree to doing a pre-treatment peak flow, particularly in those really severe cases. But the evidence is actually we should be encouraging them to do that, because that making the patient force air out to actually conduct the peak flow shifts some mucus, and it opens up some of those really distal airways that haven't had any air in for a while. That patient taking that real deep breath and forcing that breath out opens up some of those little airways, and it makes the salbutamol a lot more effective. So there is a lot of good evidence around, even in severe cases, trying to get them to do a peak flow. Clearly you can't force someone to, but and it can be very difficult to convince them of the benefits when they are gasping their last, or they certainly feel like they are. So anyone can do this. Encouraging use of their own reliever inhaler, it's key, just to make sure you appreciate that there are many types of inhaler out there, but just about everyone with asthma will have a reliever inhaler, and it's normally the blue salbutamol one. But of course there are other people that are on more complex treatment regimes may not have the blue salbutamol inhaler, but they will know which one is their reliever, so make sure you're giving them the right one. The brown beclomethasone that we often give second line for people that have kind of mild to moderate asthma won't do anything in the acute phase. It won't do anything for the asthma attack. So there's no point giving it to them, basically, but encouraging to use their own reliever inhaler, ideally through a spacer. We know that spacer devices do help. There is no maximum dose of salbutamol. Okay, just keep giving it until they start to feel better, or more senior clinical support comes to help you. So the next steps I put in blue are for those of you that are qualified either through safe administration of life-saving meds or otherwise to administer the life-saving medications. So the next step would be salbutamol 5 milligrams for an adult. Again, these are adult doses. Check JR Calc before you give child doses. Salbutamol 5 milligrams via nebulizer. You can repeat with otherwise healthy people. You can repeat that as required. We call it back-to-back nebulizers. So you just keep giving them. Once it runs out, you fill it up and start again until they start to feel better, or until you get to hospital, or until you get to senior clinical support, whatever the option is for you at the time. The next line is if the salbutamol doesn't work, then we use ipratropium bromide, and that's 500 micrograms through a nebulizer. It's only a single dose. We don't give repeat doses of ipratropium bromide. side. We normally mix it with salbutamol and give it together. It can be given straight away if the asthma attack is severe, but you always give it with salbutamol in that case. Two reasons for that: one, it's more effective that way, and two, it doesn't nebulize particularly well, because ipratropium bromide comes in 0.5 ml or 1 ml nebules, whereas salbutamol is 5 milligrams of salbutamol is often 5 ml of fluid. Nebulizes a lot better, so it'll make sense for those of you that have done nebulizing. So those of you that can or have it available, hydrocortisone 100 milligrams, intramuscular IM injection would be the next step. Unless there's a paramedic close by, because those of you that have attended our SARM course, I'll always say the hydrocortisone always works far better intravenously. So if you've got a paramedic coming and they're nearby, just let them do it IV. But if you don't, or you don't know, hydrocortisone 100 milligrams IM is perfectly acceptable. And then I've put in red, just again, it's only for those of you that are suitably qualified. You certainly wouldn't be grabbing anyone's EpiPen to do this, but adrenaline 500 micrograms with 1 in 1,000 IM, and that is an absolute last resort. If the patient is starting to head towards cardiac arrest despite your nebulizers and everything else you're doing for them, then stab them with some adrenaline, and it may well help, and you can repeat that dose as per JALC. Most important thing probably certainly at FREC 3, FREC 4 and FREC 5 level is to make sure we're either getting some senior clinical support to us, or we're transporting to the nearest A&E while we're doing all of this. Obviously up to your appropriate skill set. Okay, those of you that can't give the drugs, obviously you are able to give oxygen just to maintain saturations between 94 to 98%. Asthma is not a red box condition as per JALC, so we don't need to give them 100% oxygen regardless. We only need to give them oxygen if their saturations are dropping, which they may well do in a severe case. But as I say, if you're able to give the other drugs, then you would do those first of all. Okay, so management of asthma. So I'm going to give you a little bit of a case study. So Karen, 36-year-old Karen, who suffers from asthma, has called 999 because she's had a nasty asthma attack sitting in the park today. When you arrive, she is using her blue inhaler. You're quite happy with her technique, and it's not doing anything. Okay, so your primary survey, it's safe to approach. She can't speak to you, but she is alert. She can't speak to you because she is so breathless and trying to get her inhaler into her. You can hear a wheeze even without your stethoscope. There is marked difficulty in breathing dyspnea. Okay, respiratory rate is 40, her saturations are 91%, and you don't have the facility at the moment to measure end-tidal carbon dioxide. Her heart rate is 155, her blood pressure is 140/90, and you decide not to do an ECG because she's still in the park. So GCS of 15, she's fully alert and fully conscious. Her blood sugar, because you had a spare pair of hands, is 4.6. Her pupils are equal and reactive to light, and they're size 3. And she has a temperature of 36.7 should you choose to do it. So JALC, you look in there. So she's a 36-year-old lady of about 5'8". She has an expected peak flow of around 440 litres per minute. She tries her best to do one. She does consent. She tries her best, but only manages to shift it about 100. Okay, so thinking back to what we just talked about, let's see if we can answer the next question. So back to menti.com. It's going to be the same number again. We're going to move forward to the next question. So A, B, C, or D, what classification of asthma attack is this? So moderate, severe, life-threatening, or near fatal. Menti.com, go to 1702-5604. Same codes again. Is this a moderate, severe, life-threatening, or near fatal asthma attack? What I'll do, I'll flick back to that last screen just for those of you that want to see. It's the address and the number to put in are on the chat box. Menti.com 1702-5604. There's all the observations. Are we talking about a mild to moderate, severe, life-threatening, or near fatal asthma attack going on here? The observations are on your screen. Go back, see how many people are answered. Give it a minute, just see if anyone else wants to have a go. So there's the obs again. Let's go back. Lovely. Let's see where everybody's going. So some moderate, some severe, mostly severe, some life-threatening, and This is, of course, life-threatening. Okay, so any feature of life-threatening would make you think life-threatening. Let's flip back to the screen and just answer why. So we've got, so you can't speak, so we know it's definitely in the severe category. The wheeze is expected. Her respiratory rate's over 40, or it's sitting at 40, so we're definitely moving into the severe to life-threatening. Saturations, that's the first point where we go into life-threatening, isn't it? Sats of 91 is concerning. Heart rate over, again, we know that's in the severe to life-threatening category. Blood pressure is not particularly useful. We have here the peak flow expected of 440. She's blown 100. That's less than a quarter, so definitely less than 33%. That puts her in a life-threatening. Actually, if you saw somebody with observations like this, don't be surprised if that moves fairly quickly onto a near fatal situation that's going on there. Okay, so well done to the 39% of you. A couple of you just voted after the answer went up, so well done to most of you there, to a lot of you there that got life-threatening. So those of you that pick severe, just bear that in mind. Once we get any feature of the next level up, we start to call it the next level up. That saturation's dropping and that peak flow being so abysmal puts her definitely into the life-threatening and possibly getting close to near fatal, depending on how she looks. Okay, brilliant. So I think we have good. So I'm going to ignore that question for now because you haven't got the case study yet. Let's go back to COPD. So what is COPD? So COPD is a group of, so what does it stand for? First of all, it's chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease is a group of irreversible and progressive. Irreversible means there's no real treatment for it. We can't stop it. Progressive means it's going to continue to get worse as the patient ages. So it's an irreversible and progressive lung diseases, of which there are a few, but by far the most common that we talk about are chronic bronchitis and emphysema. Chronic bronchitis and emphysema are the two conditions that we most commonly associate with COPD, chronic obstructive pulmonary disease. They're caused by physical damage to the lungs. They're certainly most commonly associated with smoking, but of course, lots of occupational hazards have also been linked to COPD. Asbestos, coal mining, working around lots and lots of pollution and dust inhalation, so carpenters, brickies, that type of thing. So treatment generally evolves from the primary care side of things. Treatment involves management of their chronic breathlessness. These patients are often very breathless, can't do very much in the way of physical exercise without getting very breathless. We try and manage them with inhalers and can be quite complex, but of course we do get regular exacerbations. Exacerbation just means a flare-up. And that's usually secondary to chest infection. So often when these patients present to us as ambulance services, it's because they have what we call an infective exacerbation of COPD, often written as IE COPD, and that's basically just saying you have a patient with COPD that has now got a chest infection, and that's made all their symptoms a lot worse. Okay, so what are the two types? So chronic bronchitis versus emphysema. So chronic bronchitis, we'll talk about what makes it chronic in a minute, but that's inflammation of the bronchi, so the larger of the airways within the lungs. So it's still technically a small airway disease, but it's where the lungs split. So the left and right main bronchi, where they split into smaller bronchi, so secondary and tertiary. It's those bronchi that become inflamed, and hence the name bronchitis. Okay, we'll talk briefly about bronchiolitis later, which is bronchioles, which is the smaller airways, particularly in children, they get that. So chronic bronchitis is where this occurs frequently, but it's inflammation, chronic inflammation. Chronic means over a long period of time. Inflammation and excess mucus within those bronchi. Okay. Clearly, that's going to affect air getting in and out of the alveolar sacs again, in exactly the same way that asthma did. And with that excess mucus, we're going to have a chronic productive cough. Productive cough means that we cough this up and it comes into our mouth. We either spit it out, swallow it, don't we? Emphysema. Emphysema, by definition, is damage to the alveolar sacs. Now, I said at the beginning, one of our students recently came up with a very good way of thinking about this, which is that your alveolar sacs are like a little roll of bubble wrap. And you can imagine that's fairly rigid. There's some rigidity there. So when you breathe out, they don't collapse completely. With emphysema, what happens is effectively somebody comes along and pops those bubbles. So you imagine bubble wrap now is basically just a polythene bag. So actually it can inflate, but actually when you breathe out, when the pressures decrease through everything being squeezed and air leaving the system, they collapse on themselves. Now, because all these parts of the lungs have this kind of gluey-like substance called surfactant within them, actually they stick together. and they require a fair bit of force to open them again. But sometimes what you can also get is the reverse, that they collapse on the outer edges, and as you breathe out, you can't get enough air out of the alveolar, so air gets trapped in there. But can you see in both of these cases, the same net result is happening, in that you get impaired gas exchange within the alveoli. In this case, it's because the alveoli themselves have become floppy and saggy and collapse in on themselves and find it hard to inflate and sometimes hard to deflate. In chronic bronchitis, you've just reduced the capacity for that tube to carry air to and from the alveoli, so the whole system becomes inefficient. So again, no surprises with what actually starts to happen, and that's low oxygen, high carbon dioxide, and in result we get high respiratory rates, high heart rate. And in the case of bronchitis, because it is often infection related, we start to see a bit of a rise in temperature. So what makes bronchitis chronic? The definition is it's a daily productive cough that lasts for more than 3 months of the year, for more than 2 years in a row. So for more than 2 years in a year, that's good. Don't quite know what I was trying to write there. So daily productive cough that lasts for more than 3 months of the year for 2 or more years in a row, because clearly you can't squeeze years into years. So, but that's what makes bronchitis chronic, and therefore part of the COPD kind of bracket. So recognition features very similar to asthma, actually, if you look at it, isn't it? There's not huge amounts of differences. So might struggle to speak in full sentences, might be wheezy, they might be coughing. It's certainly in acute bronchitis, as we're going to talk about later, you may well hear crackling. Those of you that have been taught to use stethoscopes and listen to breath sounds, you'll hear coarse crackles, which go away and Google some good YouTube videos, which I can put links to, that tell you what they sound like. Visible dyspnea, again, you might see that the patient is visibly breathless, their respiratory rate is going to be high, SATs might be low, or they might be normal in the early stages. End tidal carbon dioxide might be raised, heart rate might be raised, blood pressure again might be unreliable. It's not necessarily going to change acutely other than through stress. Cyanosis again in the late stages, may have a normal ECG, they may not, they might have other underlying problems. These patients tend to be older, don't they? So GCS may be again reduced in the late stages, again associated with hypoxia. Blood sugars not acutely changed by COPD, sometimes they can rise slightly in infection, not always. And again, these patients being older and unwell may well have diabetes, but again, blood sugar isn't necessarily going to tell you much here. Again, pupils aren't going to change, and your temperature might be raised in bronchitis. Bronchitis is more associated with infection, but infection can exacerbate both chronic bronchitis and emphysema. So you can see a temperature in both, but it's more associated with acute on chronic bronchitis, as we would call it. What I will say to you, just to keep a thought process out there, we'll talk about sepsis as its own session at one point, but whenever you're thinking this patient has an infection, please think sepsis. And if you think they have an infection, check their News 2. If their News 2 is over 5 or they score 3 for any one single item, then please take them to hospital and communicate the fact that you think it might be sepsis. So treatment for COPD, again, it's not going to be too dissimilar to asthma. There are a couple of little changes. So calm and reassure and move to a quiet environment as possible. That's true for anyone that's stressed, distressed, particularly with breathlessness. Ideally, again, you want to measure their peak flow before and after treatment for exactly the same reasons. We want to know how bad it is and how well our treatment is working. And also forcing them to have that forced exhale in the case of bronchitis might help clear some mucus. In the case of emphysema, might help to empty and refill some of those sacs that have all stuck together with all the surfactant, where they've collapsed on themselves. So it is beneficial to try and get your patients to do peak flows. So I know it's often forgotten. So again, encourage use of their own reliever inhaler. Again, with COPD, the medication tends to be a lot more complicated than asthma, so it's not always immediately apparent to us which one is their reliever inhaler, but the patient will have been told, should know which one is their reliever, and encourage them to use that, ideally again through a spacer. Some patients with particularly bad COPD or COPD that flares up regularly are given home nebulizers, and again, you're absolutely fine to encourage them to use that if it's being prescribed for them. So again, generally with the reliever inhalers, there are no maximum doses, but and ideally through a spacer device. If we need to give them oxygen, we titrate to a lower level. I'm going to explain why in just a little while, but patients with COPD and reduced SATs, we're only going to give them enough oxygen so that they stay in that 88 to 92. Obviously, if their SATs are higher than that, that's fine. That's not a problem. You don't have to put a paper bag over their head until they come down to 88 to 92. But you have a hard time explaining that one. But you certainly, if they come into that range, leave them alone. You don't necessarily need to give them oxygen. If they drop below 88, then start to give them some low flow oxygen to bring that up. Again, the things in blue are for those of you that have done safe administration life-saving meds or local equivalents. Salbutamol 5 milligrams via a nebulizer. We can repeat it as required, but there is this kind of note here that we should limit to 6 minutes at a time if the nebulizer we're using is oxygen driven. Now, I know there are some air driven nebulizers out and about. Patients get given them when they're really bad with COPD. I know there are ambulance services that carry air driven nebs. They're generally mains powered, which is the main reason we don't use them on ambulances. But if we're using an oxygen driven nebulizer, which 99% of the time we are, we need to limit that to 6 minutes at a time. I'll explain why we don't want to blast this patient with too much oxygen. The next step, again, as with asthma, if the salbutamol doesn't work, we can give them a single dose of ipratropium bromide, again through the nebulizer. Same doses as asthma. These are for adults. Children don't get COPD, but if you're treating a child with asthma, then do consider the doses. So again, as with everything at this level, senior clinical support and or transport to the nearest A&E. Ultimately, we know that some COPD patients are complex. We know that some of them have care plans that say they're not for hospital admission wherever possible. We know that we're going to have to get out of hours GPs or the patient's own GP involved and community respiratory teams sometimes. We know these aren't straightforward patients, so getting that senior clinical support to help you is going to be a great amount of use. And of course, if the patient is acutely unwell, if you're thinking sepsis on top of COPD, then absolutely transport to the nearest A&E is almost certainly going to be the most appropriate thing. So why are we worried about oxygen in COPD? So keeping it simple, patients with COPD, as we've just described, they have chronic bronchitis or they have emphysema. Both of those diseases mean that for the vast majority of that patient's kind of remaining life, they are going to have lower oxygen saturations and higher end-tidal carbon dioxide levels than healthy patients, because gas exchange is to lesser or greater extent impaired somewhat, isn't it? Air can't get in and out of the alveoli as effectively as it would in a healthy patient of the same age. So healthy patients rely on end-tidal carbon dioxide levels rising to stimulate breathing. So if I hold my breath, or if any of you hold your breath, the stimulus you get to breathe is being driven by carbon dioxide rising in your blood. It responds a lot quicker than oxygen. Those of you that have done our FREC 4 courses will have seen my demonstration where I hold my breath and then go and pant away till I'm nearly fainting, just to show you how quickly your CO2 does change, whereas your oxygen tends to stay the same. So end-tidal carbon dioxide rises and falls quite quickly in the blood, and the healthy body uses that to stimulate us to breathe. It tells the brain, when we're not thinking about it, in the autonomic nervous system, it tells us whether to breathe faster or slower. Patients with severe COPD, so COPD that's progressed beyond the kind of just a bit breathless from time to time, it's a bit of a theory, but they're thought to switch, the body automatically kind of switches to relying on their oxygen levels instead. Because the carbon dioxide levels are so chronically high, it's almost as if those sensors just get turned off because they're always telling the brain to breathe faster, and the brain says, oh, shut up, you don't know what you're on about. And it starts relying on the second line, which is the oxygen levels. Now, oxygen responds a lot slower. So when you hold your breath, your oxygen saturations can actually take quite some time before they even drop a point or two. They generally don't drop very much because you get the stimulus to breathe from your carbon dioxide. But a COPD patient could probably hold their breath for a bit longer in this theory, couldn't they? So if their oxygen levels drop, then they get the stimulus to breathe. This theory is known as hypoxic drive. If you've ever come across this word, hypoxic drive, it's because these patients are relying on hypoxia to drive their respiratory system. Okay, so the theory is that if we give them too much oxygen, it is in theory possible to remove their stimulus to breathe, particularly if their level of consciousness is quite low to begin with. Okay, so you'll see in JR Calc and other kind of the British Thoracic Society guidance, etc., that if we give too much oxygen to a patient with COPD and they were already a little bit drowsy to begin with, we may well make them more drowsy and reduce their stimulus to breathe. Obviously, the net result is take away the oxygen and support their ventilations with room air ventilation if we can until that passes. It's still a bit of a hypothesis rather than a proven fact. And it's not particularly well understood, but this is why we worry about oxygen. This is why we have conflicting guidance sometimes around COPD. We do therefore allow patients with COPD to have tolerable SATs kind of a little bit lower, so permissive kind of hypoxia, if you like. So we will allow somebody with COPD for their oxygen levels to drop down to 88 before we do anything about it, whereas a normal healthy adult, of course, we would step in at 94, below 94. We generally always avoid the use of 100% masks in COPD. There is some real confliction around sepsis guidance, though. Patients with COPD that we're also concerned about sepsis, some trusts have published guidance which suggests that we should give 100% oxygen to those patients, even though they have COPD. It's not supported by everybody that's involved in making those decisions, but unfortunately it's not particularly well understood that we can give a definitive answer. So depending on where you work, we'll tell you whether to give 100% oxygen to COPD patients that have sepsis or major trauma, or etc., etc. But in most cases you do. But generally, otherwise, we try and avoid giving them too much oxygen. Hopefully that makes sense. And that's all because they are relying on their oxygen levels to tell them to breathe. And if their oxygen levels come up high, they'll stop breathing. It didn't make sense to me the first time I heard it. So I appreciate it may not immediately make sense to you. So how are we doing for time? So we are going on to our next case study. So John's 55, he's a heavy smoker, suffers with a lung problem. He doesn't know what it's called. When you say COPD, he says, yeah, that's the one. He called 111 today because his cough is getting worse and he's struggling to breathe. When you arrive, he's sitting forward in that tripod position, so we're already starting to think maybe he's got some difficulty breathing. It's safe to approach John. He can only say the odd word because of his breathlessness, but he is alert. He's coughing frequently, but his airway's patent. He has marked difficulty in breathing again, respiratory rate of 24, SATs are 89, and end-tidal carbon dioxide. This time you have a LifePak result that can measure it, 6.8, so slightly raised. Normal is 4.6 to 6. Heart rate of 101, blood pressure is 140 over 90, and his ECG appears normal to you. He's fully alert. His blood sugars are 6.2, and his pupils are normal. He has a low-grade fever, 37.9. John's inhaler has run out, but you're with a colleague who has completed their SARM training, or you yourself have completed SARM training if you have. John does not want to go to hospital. He just wants someone to arrange antibiotics for him. So let's go to menti.com. And if you can see that, so menti.com 17025604 again. Which of the following is correct? So John should be given oxygen first because his saturations are low. His saturations are 89%. We should be giving him some oxygen. John can be given salbutamol without restriction. John should be given ipratropium bromide straight away, as this is a severe case of COPD exacerbation. Or John can be given salbutamol through an oxygen-driven nebulizer, but only for up to 6 minutes at a time. Which one of those is correct in this case? John should be given oxygen first because his SATs are so low. John could be given salbutamol without any restriction. John should be given ipratropium bromide straight away because he is quite clearly struggling and it's severe. Or John can be given salbutamol through an oxygen-driven nebulizer for up to 6 minutes. Have a little think. A, B, C, or D. What do you think you would do in that? Or what do you, if you haven't done SARM based on what we've just talked about this evening, what would you expect your SARM colleague to do? Let's have a little go. I'll try and let half of you have a go before we show the screens. No, there's only about 17 or 18 of you with smartphones out there by the looks of things, so there we go. 18% of you saying he can have as much salbutamol as he likes. It's true, but he can't have as much oxygen as he likes. 6% of you thinking he should have ipratropium bromide straight away as it's severe. That rule only applies to asthma, so 76% of you are correct. That John can be given salbutamol through an oxygen-driven nebulizer, but only for up to 6 minutes. There is a restriction on that. If it was his own nebulizer, which was air-driven, there would be no restriction. But in this case, he cannot. The most correct answer there, 76% of you have got, is that he can have oxygen through an oxygen-driven nebulizer, but only for 6 minutes at a time. Okay, just remembering those of you that went for ipratropium bromide. In asthma, we can mix ipratropium bromide with salbutamol first line if we think it's severe. But generally speaking, we do salbutamol first and then ipratropium bromide after that. Good, well done. Let's come back to, oh, we've done that. Chest infections. Okay, broadly speaking, chest infections are covered by respiratory tract infections, to be properly termed. Lower respiratory tract and upper respiratory tracts, they're known as LRTIs and URTIs respectively. Okay, the two main lower respiratory tract infections that people think about are bronchitis and pneumonia, and we'll just try and explain a little bit around the differences. We've come across bronchitis in the terms of chronic bronchitis in COPD. That's exactly the same, but this isn't happening time and time again. This isn't as a result of lung damage. This is the most common chest infection. This is what people, when people say they have a chesty cough, productive cough, they've got a chest infection brewing, this is what they're talking about 9 times out of 10. Most of the time it's viral, doesn't need antibiotics. Every now and again it's bacterial, and it does. There is some evidence actually that antibiotics do help with some viral chest infections, just to confuse everyone. But there we go. So it's one of the most commonly prescribed, or the most commonly reason for prescribing antibiotics in primary care is for a suspected chest infection, and almost always we're thinking it's bronchitis. Inflammation of the bronchi, the bigger airways within the lung, and excess mucus production. Okay, and it does that in an attempt to try and get rid of the muck or whatever it is that infection that's nested. Most healthy people can clear it by themselves. You cough it up, that's the whole point. You're coughing up all the muck. And then eventually your immune system takes over and clears it all up. Some people need antibiotics to help it, particularly if it's bacterial, particularly older patients, particularly younger patients. We also have bronchiolitis. Bronchiolitis, those of you that have kids may well be aware of that, and that's just the same process but going on in the smaller airways. So remember, if it's bronchial in the same way as arterial and venual, it just means it's a small version of the above. Okay, so a bronchi, a small bronchus is a bronchial. A small artery is an arterial, a small vein is a venual. Okay, hopefully that makes sense to you. So bronchitis and bronchiolitis are effectively the same thing, but it's bronchiolitis is more of a child thing. Bronchitis is more of an adult thing. If you get bronchitis for more than 3 months of the year for 2 years in a row, we would call it chronic bronchitis, and that's most likely to be from airway damage. Good. Pneumonia then. Pneumonia, what is pneumonia? It's fluid buildup in the alveolar sacs. Okay, so yes, Don, we're going to come on to aspirational pneumonia. Very good. One type of pneumonia. So pneumonia is fluid in the alveolar sacs. Now it's normally there because of an infection or something that's come in that's caused infection. Aspirational pneumonia is, of course, inhaling of vomit. Okay, in its crudest terms. So if you get anything from the stomach that makes its way down into the trachea, and you inhale that, and it settles down in the lungs, it causes an infection. It can often cause aspirational pneumonia. Pneumonia is just fluid buildup, as you can see from the diagram there, within the alveolar sacs as a result of infection. Now that fluid buildup, it promotes the growth of pus. So we have we often you get pus is dead white cells effectively from your immune response. So that pus forming within the alveolar sacs can actually block them off. And obviously air doesn't conduct, so oxygen and carbon dioxide doesn't conduct through that pus or through that fluid buildup within the sacs. Of course, it impairs gas exchange in exactly the same way as everything else we've talked about this evening. And of course, that widespread infection can overwhelm the immune system, and actually it's one of the very common causes of sepsis. So, and anyone you're thinking about pneumonia, you've just got to have sepsis sitting on your shoulder, just reminding you that they exist. Okay, so so that's the difference between bronchitis and pneumonia. Bronchitis can cause pneumonia if you don't treat bronchitis, particularly in the elderly folk. That infection can spread further down the system and can come down to the alveolar sacs and cause that fluid buildup, cause pus buildup, and can cause some real problems there and overwhelm the immune system, make the patient very unwell. So lots of different types of pneumonia you'll hear out there, but basically they're all referring to the same pathophysiology here. So you'll hear community acquired and hospital acquired pneumonia. It's exactly the same thing. It's just the patient got unwell at home or the patient got unwell at hospital. Hospital acquired pneumonia is one of the main kind of things we think about, particularly with older folk. When we're thinking as a reason not to take someone to hospital is actually their risks of acquiring hospital-acquired pneumonia. There are lots of unwell people in hospital, and any chest infection can settle in and cause pneumonia, particularly in an immunocompromised patient, a person with a poor immune system. Then we have aspiration pneumonia, good, and that's kind of. And then so the other thing we can you may well hear is lobar pneumonia. That was the other one I was just going to mention. You'll recall from the anatomy and physiology session that the right lung has 3 lobes, the left lung has 2. It has 2 because the heart occupies some of the space that it would have that would be the middle lobe if it was symmetrical to the right. So the lobes themselves can become blocked off with pneumonia. Lobar pneumonia is where that pus and fluid buildup has spread and blocked the bronchioles effectively that feed that whole lobe. So you can get a whole lobe knocked out, and you can imagine what that will do to your oxygen levels and your carbon dioxide retention. So good question that's come in from Robert. Would oxygen-driven nebulizers raise the oxygen saturations in a COPD patient? Yes, they would. Ultimately, I seem to recall when you're giving 6 to 8 litres of oxygen through most of the nebulizers that we buy, the ProAct ones in UK ambulance services, the patient's getting somewhere between 40 and 50% oxygen. Normal room air is about 21%, so they're getting at least double what they would be if you had them on a room air driven oxygen nebulizer. So you will increase that concentration gradient if you get the patient to breathe in through an air driven nebulizer. The amount of oxygen in their alveolar sac when they breathe in is still only going to be 21%. If you're giving them 40%, it's going to be 40% when it gets down there. So of course the concentration gradient is going to be higher. If their oxygen levels are lower, then that is going to increase the gas diffusion across those cell walls. And will naturally increase their oxygen levels, and that's one of the main reasons we don't give them their nebulizers for more than 6 minutes at a time. Hopefully that makes sense to you. There is something called the CRB 65 score, which can be particularly useful. There's another one called the CURB, CURB 65 score, which is more for in-hospital use because we can't measure the U of that. But CRB 65 is the one we use pre-hospitally. And we're looking for 4 things, and we get a point for each. Okay, so we have. I just realised I put the scoring system for CURB, so just a score of 4. Not you can't score 5 on this one, obviously. So each of the following scores 1 point. So new confusion, a respiratory rate over 30, systolic blood pressure less than 90, or a diastolic of less than 60, so a drop in blood pressure, and age 65 or over in a suspected pneumonia patient. So if you go to a patient you think, yeah, pneumonia could be a possibility here, are they confused? Newly confused. Obviously if they have dementia type illness, then that might not be so useful. Is their respiratory rate 30 or greater? Is their systolic blood pressure less than 90 or the diastolic less than 60, signifying that they are dropping their blood pressure, and are they age 65 or over? If their respiratory rate's 30 or over, please be thinking about sepsis as well. Don't just say, oh, the CRB 65 says they're fine. Just that this is just saying that unlikely to have pneumonia if they have only scored 0 or 1. Okay, low risk 0 or 1 means it's unlikely to be pneumonia, but this patient does still need to be monitored. And actually, if they are still unwell, then going to hospital may still be the most appropriate thing. Score of 2 is moderate risk. I put AECU, which is ambulatory emergency care unit. That's often the kind of the watered down version of A&E, depending on where you work, for patients that need to go into hospital to be seen today, but they don't necessarily need to go and sit in A&E and clog up a bed. If they're ambulatory, i.e. they can walk, we often take them to or refer them to ambulatory emergency care units. Where you work, you'll know whether your hospital has that or not, that step down kind of A&E facility, a bit like acute medical unit that we can directly access. So a score of 2, you're thinking moderate risk, you're thinking something along the lines of acute, that or a same day face-to-face GP appointment. Difficult to get sometimes, but that type of level. A score of 3 is severe risk. For us as ambulance folk, that's almost certainly going to be an A&E visit. I mean, if you're looking at somebody with a CRB of 60, a CRB 65 of 3, they're unlikely to be ambulatory, are they? They're unlikely to be able to walk into a hospital. And a score of 4 in this case. The reason I put that 5 is on there is because actually the one that they use in hospital is CURB, which is where they measure urea within the blood, and that would score you the 5th point. But either way, if you're scoring 4, then you're actually just saying that they have a high risk of mortality, they have a high risk of dying here. So again, for us, A&E, then, and report that CRB 65 score, and that will certainly help them focus their attentions. If you're thinking this patient has pneumonia, community-acquired pneumonia with high CRB scores carries high mortality in the over 65s, we know that. So it may well mean that they need to go to ITU or so on and so forth, but it'll be useful for hospital to know. And then we'll finish off tonight with some upper respiratory tract infections. It's more just a kind of a quick chat around what they are. excuse me, as I start coughing with the mention of respiratory tract infections. So we're going to talk about a few here. The itis basically means inflammation of, okay? They're not shown here, but you have sinuses within the bones of the skull that contain some soft tissue, and that can become inflamed. Sinusitis can be quite painful. It can be quite tricky to treat as well, because the blood supply to those areas isn't particularly good, so antibiotics take a long time to work. But sinusitis is quite literally inflammation of the sinuses. That's classed as an upper respiratory tract infection. Rhinitis is inflammation of the mucous linings of the nose. Quite common with allergic rhinitis is the posh word for hay fever. A lot of people get chronic rhinosinusitis, etc., which is constantly having kind of blocked nose, runny nose, stuffy nose and blocked sinuses, that type of thing. So that's inflammation of the lining of the nose. Pharyngitis is your classic sore throat. So the pharynx is the back of the throat, and if that skin there or those mucous membranes become inflamed, that would be classed as pharyngitis. Laryngitis is inflammation of the voice box, this area around here. Again, sore throat, but a little bit further down. One thing I missed off there is tonsillitis. Of course, they're not marked on this gauge here, but they're obviously at the back of the throat, aren't they? Tonsillitis being inflammation of the tonsils specifically, but within that area of the pharynx. Laryngeal edema I've put on there because swelling of the voice box as a result of an infection can cause croup, particularly in children. And epiglottitis is inflammation of the epiglottis. It's this flap of skin here behind the tongue that isn't labelled on this diagram. That is a bit of a time-critical emergency. Epiglottitis affects children. It can often be a bacterial infection that can make them very unwell. The risk with the epiglottitis is the epiglottis can spasm. If it spasms, it shuts and it will occlude the trachea. Of course, if you occlude the trachea, air does not go in and out. And that is one of the first rules of life, isn't it? Air must go in and out and blood must go round and round. Any variation on that is going to cause you problems. So that's just some upper respiratory tract infections for you to be aware of what they mean. Again, what are you expecting to see with anyone with a respiratory tract infection? Normal levels of response. You know, there may be some breathlessness, there might be some coughing, there might be wheeziness, there might be those coarse crackles, particularly with anything that's resulting in excess mucus build up on the lungs. You'll hear that as coarse crackles through your stethoscope. Some difficulty in breathing is of course possible with anything respiratory related, the level of which is probably going to decide how quickly you're going to act. High respiratory rates, low SAT, high end-tidal CO2, all of the diseases we've talked about tonight are going to give you the same net result. If air does not get in and out of the alveolar effectively, we're going to have all of the same symptoms. The only thing really that's going to change is whether or not we have a temperature with it, and that may help you decide which way we're going. High heart rate, blood pressure in the normal range, cyanosis in severe cases. Again, no acute ECG changes really with any of these respiratory tract infections. They're not going to do anything to the heart in the early stages. GCS, again, levels of consciousness are going to reduce in the late stages of any illness. Blood sugar, unlikely to be that change. There is some evidence of blood sugars rising in when the body's immune system's working hard. And in sepsis, particularly, we're seeing rises in blood sugars. But generally speaking, we don't see much in otherwise healthy people of a blood sugar rise. Pupils not doing anything, you are going to see a rise in temperature. With anything that's caused by infection, anything that's triggered your immune system, you're going to see a rise in temperature. The golden rule is if the temperature's going off the scale, it's probably bacterial. If it's holding a sensible temperature, it's more likely to be viral, but that is never going to be cut in stone or set in stone or whatever the word is. So you can't rely on that all the time, but generally speaking, viral infections don't cause as much of a temperature rise. So again, if you're thinking infection, please think sepsis. Check everybody's News 2 score if you're thinking they have an infection. That's what it's there for. It's to spot sepsis. Any single red item or a total of 5 or more, you've got to consider sepsis and take them to hospital if they will consent. So your last case study of the night, there's a few questions associated with this, so I don't know if you want to scribble down some notes as we go. So Peter is 66 and he's normally well. He calls 111 today because it's the weekend, he's had a nasty cough and he can't shift it. He doesn't think he can last till Monday to speak to his own GP. When you get there though, he does open the door and he does greet you. So he's obviously not too breathless and he can't walk. It's safe to approach the house. It's a lovely house in suburbia. He is alert. Obviously, he's walked to the door to let you in, hasn't he? He's got a patent airway. He's occasionally coughing when he's there. Let's ignore the fact that COVID's going around. We're not thinking that at the moment. Slight dyspnea. He's got some slight breathlessness that you notice. You sit there and you count his respiratory rate, or your crewmate does, and you're alerted to the fact that it's 28, despite him sitting down and relaxing. Sat to 94. Low end of normal. End-tidal CO2 is not available. You haven't got, so you've just brought in your basic obs kit to this job. 111 cough. I mean, Would you really? C, circulation. In this case, his heart rate's 138. That's quite quick. Hey, your crewmate kind of looks at you and goes, heart rate's up. So blood pressure 100/50. 66-year-old chap, probably thinking that's a bit low. Do an ECG. That sounds sensible, doesn't it? A bit breathless, coughing, bit, obs are a bit deranged. Sensible to do an ECG. That looks normal to your expert eyes. GCS of 15. He's not confused in any way. Blood sugars are a little bit raised, aren't they? 8.1. He might just be diabetic and not know it. You never know. And pupils aren't doing anything weird or wonderful. Does have a temperature though? Cracking temperature 39.3. I know obviously now we'd all be putting our spacesuits on and painting red X's on the door, wouldn't we, and naming him COVID and telling everyone. But no, we'll assume it's not COVID. This is before COVID existed. And Peter tells you he's been taking paracetamol regularly for the past week, trying to shift whatever this is that's going on. He feels dreadful, but he really would rather not go to the hospital. He's been seeing how under pressure they are at the moment and would really rather stay at home. So might be worth just jotting down some of those numbers. What do you think? Get that into your head a little bit. What are we thinking about here? Is Peter would rather not go to hospital, but looking at those obs, what are we starting to think about? I'm going to go over to menti.com and pop in the same code again, 1702 5604. The first of 3 questions, what is the correct treatment plan? So you have 4 options here. So Peter would really rather not go to hospital, but you have the option of gaining his consent, taking him to hospital and placing a pre-alert as you think he's actually really unwell. Okay. You have the option of giving Peter a salbutamol nebulizer and then reassessing him. You have the option of respecting Peter's wishes and arranging an out-of-hour GP call. Or you have the option of asking Peter to contact his own GP when they're next open. Which of those do you think is the most appropriate? So A, B, C, or D, trying to gain his consent to take him to hospital. If he consents and you pass a pre-alert because you think he's really unwell, give him a nebulizer and see what his obs are doing then, and then reassess and decide what you're going to do with him. Respect his wishes that he doesn't want to go to hospital and arrange for an out-of-hours GP to call him. Or just say, do you know what, it's Saturday night, Sunday morning, whatever. Your GP opens tomorrow, you can see them then. What would you do? Give everyone a minute or two. Give the 17 loyal smartphone followers a chance to vote. A, B, C, or D. Hospital with a blue call, salbutamol and reassess, respect his wishes, or ask him to call his own GP. There we go. Well, 16 of you have voted. Bit of a split there, isn't there? Okay, 17, there's the 17th one lurking. Good. 65% of you saying gain his consent to take him to hospital, place a pre-alert. Interesting. A quarter of you saying give Peter salbutamol neb and then reassess. Okay. 12% of you saying respect his wishes. Nobody's saying call his GP on Monday. I'm glad. That probably wasn't a sensible option in this case. Okay, and somebody else just gone for giving him a nebulizer and then reassess. So you've got to ask yourself, why are we giving him a nebulizer? Is he showing signs of COPD, or is he showing signs of asthma? If he is not, then we can't give him a salbutamol, nebulizer. Respecting his wishes and arranging an out-of-hour GP call probably isn't going to be your first line. Ultimately, if you can't get A, then you're going to have to go with C, aren't you? Because if we can't take someone with capacity against their will, even if they may be life-threateningly unwell, as Peter may well be. Okay, so gain consent, take Peter to the hospital, place a pre-alert call as you think he might be really unwell. Obviously, if he consents. If he doesn't consent, we have no option but to respect his wishes. Good. So why is hospital the only option? It's the you get one answer here. 1702 5604 again. It should have just populated. Now I've moved on. Red flag sepsis. Boom, straight in there, whoever that was. Sepsis. Sepsis. Everyone's shouting sepsis. I'm glad something has stuck in. IV antibiotics. Yeah, I agree. Sepsis, long-term sepsis. That's the Italian sepsis. Sepsis, red flag sepsis. Good. I like it. Excellent. Well done, folks. Yes, it is indeed. He is showing signs of red flag sepsis. His heart rate was over 130, his respiratory rate was over 25. That's 2 red boxes straight away with a temperature of 39 point, whatever it was. We are absolutely thinking sepsis. It's if Peter declines to go to hospital, he needs to be fully aware of the risks he's taking. So that's why the first line would be to try and get his consent, take him to hospital, place a pre-alert, and of course telling the triage nurse that you are coming in with CPC. Sepsis, very good. I like it. So, and the final question: how much oxygen did you give Peter? None, because his oxygen levels are 94%. 100% through a non-rebreather mask, that's 100% mask. 24 to 60% through a Venturi, or 6 litres a minute through the nebulizer. We're not going to give him any oxygen because his SATs are 94%. He's otherwise well, wasn't he, at the beginning? 100% through a non-rebreather, 24 to 60 through a Venturi, depending on which Venturi mask you have available to you, because we know trusts all carry different ones. And 6 litres a minute to the nebulizer. Which one do you think? Everybody have a little vote. It's the last question of the night. Menti.com 1702 5604. Which oxygen? I didn't catch that. Oh, as Siri tries to answer for us. Don't say the word. Anyone else can have a go? A, B, C, or D? How much oxygen are we giving Peter? None. 100%. 24 to 60% through a Venturi, 6 litres through a nebulizer. I'm going to put what you're all going for. 13% none, 20% Venturi, 20% through the neb. We've already said we're not having a neb, so those 20% are sadly incorrect. 53% of you now saying 100% through a non-rebreather mask. You are, of course, correct. Red flag sepsis falls into the red box guidance for JALCalc for oxygen administration. So it is 100% regardless of their saturations. The question would get a little bit more difficult if Peter had COPD. Would you still give him 100%? The 2 trusts I work for both say yes. The Sepsis Trust perhaps says no. The British Thoracic Society perhaps says no. So whether that guidance will change at any point, I don't know. But at the moment, yes, if Peter had COPD where I work, you would give him 100% as well. So regardless of his oxygen levels, 100% for sepsis. Very well done to those of you that got that. So that brings us to the end of this evening's session. Thank you very much. I hope that's been useful to you. Sorry we've gone over a little bit. It's I'm glad that we split this up into so many sessions now, because otherwise we'd be here at like 11 o'clock at night. But there we go. It's the first session of pathophysiology. There'll be another one next week. Okay, next week we're going to focus on the cardiovascular system. So we are going to look at some of the diseases that affect the cardiovascular circulation. So angina, heart attacks, acute coronary syndromes, atrial fibrillation, a few other little bits and pieces like that. I'm glad that's all been useful to you. Thank you for coming along. That will be next Monday, a week today at 7 o'clock again. Okay, first part 2 of the pathophysiology sessions. If you've liked tonight, we're always really appreciative if you can leave us a review. We do appreciate your time to do that. Charlotte's just put some links in there before they disappear. We really do appreciate the reviews. It helps us keep these free because ultimately it helps us bring in new customers. And we would like these to be free. If you would like a CPD certificate for tonight, there'll be a link appearing in the chat if it's not there already. Yep, Charlotte's given the thumbs up. So there's a link in the chat for the CPD certificate. If you need to dash off, you can't see it. It will be on our Facebook page once the video is uploaded, and through our website, the CPD section of our website within the next couple of days. If you do miss it, don't panic. You will have another chance to get one. So free CPD certificate, you just have to fill out the feedback form. The feedback form is only seen by us, so we're always grateful if you can leave us a review. And now is the question time. So those of you that are done, don't have any questions, you're free to leave. We'll see you next week, 24th of May, hopefully at 7 o'clock. And of course, these are all recorded. So if you do miss them, we can we'll put them up on YouTube for you. So any questions? Let me just roll back quickly just to see if anyone has thrown any questions in. Doesn't look like it. So the links for the certificate are in the chat. As I say, the links for our Facebook, for our review pages are in the chat. We're always grateful. No, don't have to. And if you have any questions about what we covered tonight or anything in general, then please do throw them in. You're welcome. Thank you to everyone that's come along, and you're welcome. We hope it's been useful, and spread the word, and see you all next week.